Good morning, everyone. My name is Julius Rex Sancho, and I will be talking about reducing hospitalization through pneumonia prevention and management in the nursing home. But before we talk about pneumonia, let's talk about the learning objectives of this presentation. So, at the end of the session, the participants will be able to identify the risk factors for pneumonia in elderly. Number two, recognize clinical manifestations of pneumonia. Describe treatment management for elderly residents with pneumonia. And lastly, determine ways to prevent pneumonia in the elderly. So now let's talk about pneumonia. What is pneumonia? Pneumonia, in simple terms, is the infection of the lungs, or it's the infection of the lower respiratory tract. It impacts your bronchus, your bronchioles, and your alveoli. The alveoli is very important because it is where the exchange of your oxygen and your carbon dioxide takes place. And what is the causative agent for pneumonia? It could be caused by bacteria, the viruses, the COVID 19 could cause pneumonia, and other microorganisms such as fungi, protozoa, and parasite could also cause pneumonia. So, what are the types of pneumonia in relation to where it is acquired? If it's acquired in the community, then it is called a community acquired pneumonia or the CAP. If it's acquired in the hospital, it is known as the hospital acquired pneumonia or the ventilator associated pneumonia. It is also known as your nosocomial pneumonia. When the pneumonia occurs in the nursing home, then it is known as the healthcare associated pneumonia or the nursing home acquired pneumonia. The nursing home acquired pneumonia causes nearly one third of all hospital admissions in the nursing homes. Now, pneumonia can be classified into the structure of the lungs that is affected. So, when one lobe of the lung is affected or there is consolidation in there, that is called lobar pneumonia. When it is scattered all over the lungs, then it could be your bronchopneumonia. So when you look at the x-ray, you could see patches all over the lung field, which is your bronchopneumonia. Interstitial pneumonia is not really common or sometimes known as the atypical pneumonia. It affects the cells between your alveoli. Okay. So in X-ray, you could also see some patches just like your bronchopneumonia. So that's your interstitial pneumonia. So before we delve into the pathophysiology of pneumonia, it is really important to learn about the normal lungs. Well, the lungs, you guys are familiar with. On your right lung, there are three lobes, and on your left lung, there are two lobes. And if you look at it, the part of your lungs will be your bronchus, that it will branch into smaller branches, which is your bronchioles, and at the end, and there's like kind of like a sac. It's called your alveoli sacs. In the alveoli, as what I've said, it is where your carbon dioxide and your oxygen exchange takes place. Because there is a lot of, if you look at it, there's a lot of capillaries in there, and there are semi-permeable for oxygen for the gases to exchange to takes place. So this is pretty much, your normal lungs. So let's look at the incidence of pneumonia globally. or in the United States, it is the sixth leading cause of death. Pneumonia, mortality from pneumonia is highest in older adults. And nursing home acquired pneumonia is the leading cause of hospitalization, morbidity, and mortality in the long term care facility. That's why it's important that we need to learn how to identify and to manage pneumonia, especially in the nursing home setting. So, what are these etiologic microorganisms of pneumonia that is present in the adult? For the community acquired pneumonia, the most common bacteria or microorganisms is your Streptococcus pneumoniae. Okay, next you have your Haemophilus influenzae, the Staphylococcus aureus, Mycoplasma pneumonia, Legionella pneumophila, and the coronavirus, which is your COVID-19. Um, but it's less common compared to your number one, which is your Streptococcus and your Haemophilus influenzae. But what about in the hospital acquired pneumonia or the healthcare acquired pneumonia, which is your nursing home? The most common causative agent there, guys, is your pneumonias aeruginosa and also your staphylococcus, especially your MRSA, and also your Klebsiella pneumoniae. So let's discuss about the risk factors of pneumonia in the elderly. Okay, so of course, risk factors is advanced age. So if the resident is, if the resident's age is 85, they are more at risk compared to their counterpart um, who are under 60s or 65 years of age. Gender research have shown that male is more prone to have pneumonia compared to the female. Immunocompromised status, those residents who are, who has cancer or on a chemotherapy, who have kidney problems, they could be, immunocompromised. That's why they're easily attacked by these microorganisms, and as a result, they will develop pneumonia. Also, those resident who has underlying diseases, like for example, lung diseases, like for example, COPD. Resident who have asthma, resident who has cancer of the lungs could also, make the resident prone to have pneumonia. Those residents who have impaired swallowing, those residents who just have CVA, that causes impaired swallowing. Why impaired swallowing? Because if the resident has impaired swallowing, then there is a tendency that this resident will develop what we call aspiration pneumonia. So instead of going to the esophagus, the fluids or the food could go into the lungs, causing consolidation, edema, and pneumonia. Malnutrition as well. So with malnutrition, they're also immunocompromised when they're malnourished. So it's really important, guys, that we assess the resident for malnutrition and provide necessary nutrients. Your dietitian, really has to assess resident for malnutrition. And of course, resident who have altered consciousness. These are, your risk factors. In addition, resident who has underlying cardiac disease or diseases, just like your CHF, could be prone to develop pneumonia. The use of antipsychotic and anticholinergic. Why? Antipsychotic, one of the effect of your antipsychotic is your EPS, your extrapyramidal symptoms, which could cause aspiration. Okay, and your anticholinergic medication also has an effect with the peristalsis. It decreases peristalsis, which makes the resident prone to aspiration as well. So it could cause aspiration pneumonia. Poor oral hygiene in the nursing home setting, guys. This is very important that we have to tell our CNAs to make sure that the residents' mouth are cleaned at night, or the removal of the dentures is really important, because what happened is our mouth is full of bacteria. Okay, um, if we don't clean that, and these residents are old and they have this and swallowing problem, and this bacteria that is accumulated in the mouth could go into the lungs, which could cause pneumonia. Residents who are poor functional status, especially those residents who are immobile. That's why it's very important that we turn the resident from side to side, not just to prevent pressure ulcer, but also to promote expansion of the lungs. Tube feeding. Tube feeding, the risk of aspiration here. Nurses, I want you to reiterate to your CNAs that when they clean the CNA, the resident with tube feeding or peg tube, because sometimes they would lower the head of bed, right? So that for them to clean the resident easily. But sometimes they forget to put the head of bed up, which could cause aspiration, and this could lead to aspiration pneumonia. So, guys, please remind your CNAs that not to forget to prop up the head of bed after doing care. Another risk factor is those smokers, because it causes damage to the lungs defenses, like the uh, the macrophage on your alveoli, the mucociliary function in your bronchus could be affected from frequent smoking. And the last but not the least, being in the nursing home makes a resident prone to pneumonia. Do you have any questions so far with regards to the risk factors? Okay, let's move on to the next topic, which is your pulmonary defenses. It is important to know this before we delve into the pathophysiology of pneumonia. So, what are the pulmonary defenses of the body? Because once you have issues, or um, once this pulmonary defenses is damaged, then there is a possibility that this resident will develop pneumonia. Cough reflex. Cough reflex is very important because it removes your phlegm, which is filled with microorganisms, out of your lungs. So if the resident don't have that cough reflex, so those phlegms, those um, fluid and your mucus will be remain in your lungs, which could cause your pneumonia. Mucociliary apparatus. This will be destroyed when the resident is smoking um, frequently. So the mucociliary apparatus is like a little projection in your bronchus, which removes particles or phlegm, out of your lungs. Okay, so this is very important, that we maintain the health of your mucociliary apparatus. The alveolar macrophage. Okay, so as what I've told you, in the alveolar macrophage, this macrophage reside inside the alveoli. Okay, and then if there is a presence of microorganisms like bacteria and virus, then this macrophage will fight and engulf that bacteria or that virus. Okay, however, if there is a lot of virus present, or bacteria, then this macrophage can be overwhelmed and could not do its function, and it could result to pneumonia. And of course, your mucus secretion. Your goblet cells are the one that produces your mucus secretion. It engulfs your foreign bodies or microorganism, and then so that you could cough it out. Okay, so any changes in the pulmonary defenses of the body can result to pneumonia. So now in pneumonia, first there should be how does we how do we get the microorganisms into the body? So most common route would be through your mouth. Okay, if you're like eating, um, you know, um, microorganisms that stays in your mouth, or you inhale um, viruses or bacteria. Okay, then it will go um, into your bronchus, to your bronchioles, and it will settle in your alveoli. So in the event of pneumonia, because of the presence of bacteria and the pulmonary defenses were overwhelmed, and then there's a destruction of the cells, okay, in the alveoli, then it could result to increase of fluid in in the alveoli, which compromise the exchange of oxygen and carbon dioxide. Okay, now the resident will be presenting difficulty of breathing. The resident will have low oxygen because there is no exchange of oxygen and carbon dioxide. So here is the pathophysiology, the simple pathophysiology of pneumonia in elderly. So first we have aspiration or inhalation of the microorganisms. So those resident, especially with difficulty of swallowing, the tendency of aspiration is pretty high. Then we have the adherence of the microorganisms to the alveolar macrophages. As what I've told you, this macrophage will try to protect the alveoli from microorganisms. But if the resident's immune system is low, the macrophage is weak, or is overwhelmed with the amount of microorganisms in the lungs, then it will be defeated. So what will happen now? There will be inflammation and congestion that will take place in the alveoli. Next, within 3 to 4 days, there will be red hepatization since the aspiration of or inhalation of microorganisms. 3 to 4 days after that, there will be red hepatization, wherein the consolidation of oxidates, your RBCs, your fibrin, your neutrophils are consolidated in the alveoli. Okay, then the lungs will look like it will transform into a liver-like appearance. And on the 5 to 7 days, there will be deposition of fibrin to the pleural spaces, and phagocytosis in the alveoli will take place, and there will be now gray hepatization. If the resident is healthy enough, then within 8 days to 3 weeks, there will be resolution of infection. If not, if the resident is immunocompromised, then the resident needs some help like antibiotic, oxygen management, and all that stuff, so as to resolve the pneumonia. Okay, so pretty much the simple explanation of the pathophysiology of pneumonia, especially on the elderly. So, what are the common manifestation of pneumonia? I'm not talking about elderly. Just a common manifestation of pneumonia for the entire group. including the young person, uh, children and adults. So we have the fever with or without chills. Two, cough with or without sputum, dyspnea or difficulty of swallowing, pleuritic chest pain, crackles overlying affected region, fatigue, and of course cyanosis. Then you will see some bluish discoloration around the mouth and on the nail bed. And then some, of course, fatigue. You always have like, oh my God, I'm tired. Um, then sometimes they will have some general malaise as well. But these symptoms, like fever, don't usually showed up in elderly patient. So these are what we call, according to El Sol, nursing home residents were less likely to experience chills, pleuritic chest pain, headache, anorexia, myalgia, productive cough, or sometimes fever. So how do we identify then pneumonia in elderly? So first, confusion, disorientation, restlessness, delirium. This signify that there is a decrease of oxygenation in the brain. But sometimes, guys, you have to take into consideration that confusion, disorientation, restlessness, and delirium could also be a sign of UTI. Okay? Um, then there will be loss of appetite. Resident might experience mild cough. Then you would notice that, oh, this resident is frequently falling. What is going on with this resident? There's a new onset of urinary retention, and the temperature is usually low. So when you have this, it is important for you guys to assess, the resident's lung to see, if there is some fluids, some crackles in the lungs. And look at, your resident, so you know already if they have a lot of risk factors. So if the resident have this, you know your resident. If I know most of our resident has dementia, so they're confused and disoriented. But you notice that they are more confused now. So if you notice that, go ahead and assess your resident. Check the lungs for crackles, or look at the urine, see if it's foul smelling, and it could be UTI. So do something about it. Just don't ignore the signs and symptoms. It's telling you. So you have to do your part by assessing the resident further. Okay? So that we could treat the pneumonia as early as possible and we could prevent, hospitalizations. So, how do we diagnose a resident pneumonia in elderly? First, of course, clinical manifestation. Look at those atypical symptoms, which are your low fever, your disorientation, your confusion, or you could also have the chest x ray. Well, sometimes the chest x ray is not clear, right? So the doctor would usually order CT scan in some instances because it's pretty much high definition, and they could clearly see if the lungs are affected. So it's a gold standard for diagnosing pneumonia in elderly is the use of CT scan. The WC count will be pretty high because of the infection, or sometimes it could be okay because of in elderly, um, this these things could be distorted because of the physiological changes in the elderly. Blood culture is also important to identify the microorganism that is present in the blood so that you could treat them accordingly. If it's a bacteria, what kind, if it's a gram positive or gram negative, then you could treat them with appropriate antibiotic. So, what is the treatment now? Treatment management for pneumonia. First and foremost, the initial treatment that you have will be oxygenation. You need to oxygenate the resident to maintain, to maintain the function of your vital organs. Then you have your hydration and nutrition. The doctor would, if it is in the hospital, they would usually do some, IV fluids for the resident to prevent, dehydration and malnutrition. Pain management, if the resident complained of pleuritic pain, so you can give some pain medication for that. Antibiotic management, you have to be very careful, because remember, when we say pneumonia, it could be caused by virus, and virus does not react to antibiotic. Okay, so you really have to make sure to identify what is the cause of pneumonia. So if it's bacteria, then go ahead and the doctor would order antibiotic management. Um, for the resident, both in the nursing home and in the hospital, once the resident is able to, to get up and the resident feels better, then early mobilization is very important. So you could refer the resident to therapy, PT and OT, so that they could work with the resident and also prevent consolidation of fluids in the lungs if the residents continue to lie down on bed. And another treatment management, which is very important, is comorbidity stabilization therapy. As we all know, a lot of our residents in the facility has comorbidities, like for example, COPD. They could have CHF. They could have Parkinson's. They could have diabetes. So those residents with those kind of comorbidities, you also need to stabilize them, because you know what happened if the resident has pneumonia. What happened to the blood sugar? The blood sugar goes up. So you really have to treat that by probably the doctor would increase the insulin, so that to accommodate the increase in the blood sugar. So very important that you also have to stabilize um, you know the the comorbidities of the resident. Next is dealing with breathlessness. Okay, this is one of the important thing that we need to know, and we need to know how to deal with, because this could happen in in the nursing home, right? Most of the time, residents with COPD or with pulmonary disorder will develop some sort of breathlessness, or what we call shortness of breath or dyspnea. When the resident develop dyspnea or shortness of breath, it is important that we deal with this resident, or we have to provide a holistic approach, not only the physical but also the emotional and mental, because breathlessness could be caused by anxiety. Okay, so you really have to make sure that you deal with the emotion and the mental stress of your resident, not only the physical stress. So with breathlessness, most of the medical treatment will include opioids. Because if the resident is having a severe pain, this could cause or result to anxiety, and it could result to breathlessness or difficulty breathing. If the resident is anxious, then we provide anxiolytics. If the resident has asthma, then we could provide some bronchodilators through, nebulization. And of course, you could, give the resident use oxygen, um, you know, to um, to prevent hypoxemia. But what is our non pharmacological intervention for breathlessness? So, let's say, for example, in the facility, you saw that the resident is having breathlessness or difficulty breathing. What do you what do you need to do? First, listen to the patient. It is very important to listen to the patient. Research have shown that They don't recommend to tell the resident to calm down because during that time, it will not help. So just listen to the patient, talk to the patient slowly, okay? Don't be anxious because anxiety could be transferred to your patient. Fans or open windows, very important because it reduces sensation of breathlessness and it stimulates your second and third branches of your trigeminal nerve. Okay, so if you know, then they could feel that there's air if there's fan, or if try to open the window so that they could feel that the air is they can feel the air so that would lessen their anxiety. Again, guys, do not surround your resident. Okay, I don't want the CNAs there from other unit to go there and investigate and see what's going on because it's not gonna help. Instead, make sure that in your nursing staff, you need to have um, an assignment in case there is an emergency. Somebody needs to be with the patient. Very important to calm down the patient. Number two, um, somebody is pushing the crash cart so that if you need oxygen, everything is in there. Somebody is calling the doctor, okay, because so that you could save time, and if should you have to send a resident to the hospital. Another thing is relaxation training and distraction. Maybe you could do this prior to the event of breathlessness, and also your controlled breathing exercise and techniques. What I would recommend from you guys is that when you pass medication to your resident, just ask your resident to take a deep breath. If they're able to follow instruction, then ask them to take a deep breath, 4 or 5 times, and then, you know, that would help them, expand their lungs, and it could prevent pneumonia, um, later on. So, guys, when you pass medication, just ask, oh, Mrs. Smith, can you give me four deep breaths? Or you could, teach them how to do pursed sleep breathing, stuff like that. Very important. And the last topic that we're going to talk about is the prevention of pneumonia. So, how do we prevent pneumonia? So, with prevention, uh, we have to make sure that um, there will be tobacco cessation, okay? Um, Smoking, avoid smoking as much as possible because it could damage your lungs. Hydration and nutrition is also very important to keep that immune system going. Also, your mobilization and exercise, respiratory physiotherapy, your deep breathing. This could also prevent your pneumonia. Good oral hygiene is what I've told you. Guys, we have to make sure to tell our CNAs to clean the mouth of the resident, or does the mere fact of removing the dentures at night could help prevent pneumonia? Okay, and the last but not the least, be an advocate of your flu and pneumococcal vaccination. Um, Most of our residents are more than 60 years of age, and again, their immune system is not that good. So we need some reinforcement, like like the vaccine to prevent flu and pneumonia, because if the resident develop flu, it could result to pneumonia as well. So again, these are your ways in order to prevent pneumonia. And class, these are my references. If you want to read more about pneumonia, then you can look at this. And I give you all these references here. And now it's time for the question and answer. If you have any questions, suggestions, reactions, let us know or let me know. Okay. If none, then thank you very much for listening. I hope that you gain something from this presentation. So after this, I'm gonna give you a post test, and please don't forget to fill out the evaluation. Again, thank you very much.